This is Rahil Jummani. I'm clinical associate professor in the Department of Child and Adolescent Psychiatry at Hassenfeld Children's Hospital at NYU Langone Health. Welcome to this webinar of the Child Study Center. My talk today is entitled, "My Child Doesn't Need More Stimulation, So Why Treat His ADHD with Stimulants?" I want to remind you before we start my topic today that you can submit questions at any time today by typing them into the questions pane of the control panel. That's on the right side of your screen. We will answer questions at the end of our presentation. I'll start by just giving you an overview of what my talk will cover today. We'll discuss ADHD and its manifestations. We'll examine the numerous consequences of having ADHD. I'll explain how ADHD is diagnosed, and we'll highlight effective treatment strategies for managing ADHD, including medication and non-medication interventions as well. So again, my talk is titled, "Why Use Stimulants in a Child with ADHD Who Doesn't Need More Stimulation." But before we start talking about medications and stimulants, let's actually talk about ADHD itself. ADHD has been described by doctors, by physicians as early as the 1700s. If you, in fact, go back in the literature and you look at medical textbooks in Germany, one of the authors, Dr. Weikart, actually, you can see a really nice description of ADHD symptoms in a publication from 1775. So we have known about this disorder and its impact for over 200 years. So that's really important to keep in mind. ADHD has quite an impact in communities and in families and people's lives. It involves a long-term pattern of behaviors present in multiple settings that results in social, emotional, behavioral, academic, and eventually occupational difficulties. So it is a disorder that really has a notable impact, and studies clearly show this. And now we really have evidence at the level of neuroscience and brain chemistry. So if you look at individuals with ADHD, there are differences in their brains from those who don't have ADHD. So for example, there are certain neurochemicals in the brain. Two that have been clearly identified are chemicals one is known as dopamine and the other one is norepinephrine. And both of these chemicals are found to have less than the ideal level in individuals' brains who have ADHD and in specific parts of the brain. So the part of the brain that's right here in the front, known as the frontal lobe, and a subpart of that known as the prefrontal cortex, is where we see some of these deficits or less than ideal levels of these neurochemicals. And we see this in certain neuroimaging tests as well. So there is a type of test known as positron emission tomography or PET scanning that can be done. And it actually shows us that the level of blood flow in this part of the brain may be compromised in individuals with ADHD, and metabolic rates in these areas of the brain are lower too, showing how active that part of the brain is. So clearly we are seeing anatomical, neurochemical differences in those diagnosed with ADHD. That is another layer of compelling evidence for the nature of disorder, its very existence, and its critical impact. So how does someone develop the kind of ADHD brain that I'm describing, where we see some neuroanatomical and neurochemical differences? How does that happen? And this is a complex, more complex of a question than one may think, because we believe there are multiple contributions, both environmental and family or genetic. A lot of environmental factors have been highlighted, and in fact, prenatal toxic exposures are some of the most impactful environmental features that may contribute to the ADHD brain. Multiple studies have shown that maternal smoking during pregnancy puts a fetus at risk for developing ADHD. So that's notable environmental factors, the exposure to nicotine. Also, children who have fetal alcohol syndrome, clearly demonstrate a lot of ADHD symptomatology. So prenatal alcohol exposure to prematurity, low birth weight, all of these environmental factors have been linked with ADHD and ADHD symptoms. And even some environmental exposures during early childhood, such as lead exposure, may contribute to developing ADHD or ADHD-like symptoms. So there are certainly environmental factors that play a role. There is also strong, compelling family or genetic components to the presentation of this disorder as well. And in fact, there have been many studies looking at twins. If you look at twins, identical twins share more genetics in common than fraternal or twins who are not identical. And they may have, again, identical twins will have more genetics in common than non-identical twins, and also more genetics in common than siblings, who again have more genetic commonality, more shared DNA than the rest of the population. By looking at these connections, by looking at individuals who are the most genetically related to less genetically related, you can get a sense of how heritable a disorder is. And with ADHD, the estimates are quite high, 70 to 80%. So clearly there is genetic and family predisposition. And if you look at families, you will often find that when you have a patient that comes in with ADHD symptoms, there are bound to be other individuals in that family with ADHD and with other related disorders. ADHD is quite a common condition, and we believe that it affects approximately 5% of children worldwide. This is a number that has been looked at over the years and has been fairly stable and fairly consistent across different parts of our globe as well. It is, in fact, the most commonly diagnosed behavioral disorder of childhood. So what are the symptoms of ADHD? Core symptoms of ADHD include inattention, hyperactivity, impulsivity. Symptoms are often present by age 3. ADHD tends to be more prevalent in boys than girls, and we think that for every girl with ADHD, we see about 2 to 4 boys, but girls present differently, so we may not be capturing all girls with ADHD, but it does seem to be a disorder that presents more commonly in boys than girls. Girls will present with less hyperactivity, and they exhibit fewer disruptive behavior problems. They have less conduct issues. They may be more silently inattentive than hyperactive and disruptive. How do we diagnose the condition? How does someone get identified as having ADHD? We are not at the point where it makes sense to routinely provide the kind of scanning I talked about earlier, the neuroimaging test, the positron emission tomography, the PET scan. That is not something that is readily available or first-line diagnostic tool at this point. So diagnosis is instead based on persistent impairing symptoms of hyperactivity and impulsivity and inattention, or just hyperactivity, impulsivity, or just inattention. And that these symptoms cause impairment in 2 or more settings, so in multiple environments. So it's not something that's related to something that's happening with that individual in that particular place, but something that's broadly affecting their functioning across environments. And we get at this from getting a thorough history. It's critically important to observe a child. It's critically important to have in-depth conversations with their families, with their parents, their caregivers, about not only their psychiatric mental health histories, but their medical histories, their early development, their academic progress, their friendships, how they're doing socially, emotionally, behaviorally. So really an in-depth examination of not only ADHD symptoms, but every aspect of their life that's impacting on how they're doing and why they're in a clinician's office. It's critical to not only see the child and get a sense of the child and talk to their family, but also to reach out to other individuals who know the child well. Teachers can be immense sources of information. Teachers, coaches, camp counselors, others involved in a child's life who can give us a sense of what they've been going through. Questionnaires can be helpful, not only to help establish the diagnosis and to probe for symptoms, but to follow a child as you're treating the child to get a sense of how they're responding to treatment. At this time, there is no specific diagnostic laboratory or neuroimaging test that's available readily, and that is an optimal diagnostic tool. So the thorough history taking and gathering from multiple sources is really critical. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. It's in its 5th edition now, and it spells out the current criteria for providing a diagnosis of ADHD. It requires that there be 6 or more symptoms of inattention for 6 months, and or 6 or more symptoms of hyperactivity, impulsivity for 6 months. And you can, ADHD in the current DSM edition is described as being either an inattentive presentation, acknowledging that some individuals primarily struggle with focusing and attention issues. You can have a predominantly hyperactive impulsive presentation, indicating that you tend to be more hyper and impulsive, and attention is not as much of a problem. Or you can have the combined presentation with all of the above. To meet criteria, several symptoms must be present before the age of 12 years. There must be impairment, as I indicated before, in 2 or more settings, and symptoms must interfere with social, academic, or occupational functioning. And it goes without saying that symptoms are not the result of another disorder that better accounts for their presentation. What does hyperactivity look like? Someone who's fidgety, unable to sit still, who's inappropriately running and climbing, who experiences a sense of restlessness, who has difficulty engaging in leisure activities quietly. Parents will often describe these youngsters as being on the go and acting as if driven by a motor. They tend to talk excessively and loudly. Impulsivity is often seen as someone who is unable to resist the urge to blurt things out. They blurt out answers before the question is even completed. They have difficulty waiting their turn. Likewise, if they have to wait their turn in lines or in a game, it is extremely challenging for them, and they tend to interrupt and intrude on others' conversations as well. Inattention is often seen as an inability to pay attention to details, someone who makes lots of careless mistakes. They tend to be task avoidant because they struggle with sustaining attention and clearly have difficulty when they must sustain attention. They seem not to listen. They're easily distracted. They fail to finish tasks, sometimes even tasks that they will take on themselves. They tend to be quite disorganized and to lose things and to be forgetful. Untreated, ADHD has numerous consequences and can lead to low self-esteem, depression, anxiety, substance use. Academic and occupational challenges as well as social struggles are notable. Most children with ADHD have some social difficulties, and socially struggling children with ADHD experience more problems with behavior in school as well as with peers and family members. You can see why children might not want to engage with a child who's interrupting and intruding, who's impulsive, and who sometimes is not focused on dialogue and conversation. And then these children become increasingly isolated and don't think very highly of themselves. Children and adolescents with ADHD are high risk for school failure, for emotional problems, for parental and family conflict. This takes a toll not only on the child, but the entire family. And as I indicated, the real possibility of social rejection by peers, so critically important in early development. In addition, we see a high co-occurrence with ADHD of disorders involving reading, writing, arithmetic, language, coordination. In the general population, the risk of a learning disorder is about 5, maybe 10%. In individuals with ADHD, the number jumps up to much higher. Anywhere from 30 to 50% of individuals with ADHD may have a learning disability as well. So these things do tend to co-occur. ADHD also increases the risk for an anxiety disorder, tics and Tourette's, as well as obsessive compulsive disorder. About 75% of children with ADHD show behavioral symptoms or aggression and defiance fairly consistently. And perhaps, again, this may be more common in boys than girls. At this point, we believe that about 50% of children with ADHD continue to have symptoms into adulthood. So development plays a role, and a group of individuals seem to, through development, for lack of better words, outgrow their ADHD. But a sizable portion, approximately 2.5% of the world's population of adults, still has ADHD symptoms that impact their functioning. And these individuals have higher risk for traffic tickets, speeding tickets, car accidents, divorce, being laid off and being out of a job, and higher rates of being arrested. So substance use, lots of anxiety, depression, lots of consequences of adult ADHD as well. So now we come to sort of my provocative question about, so why would we use stimulants to treat? Stimulants were actually accidentally discovered almost 100 years ago by Dr. Charles Bradley in 1937, when he quite innocently thought he was using medication to treat headache. What he found was that it really had a huge impact on the youth that he was treating in terms of ADHD symptoms, hyperactivity, impulsivity, focusing issues. Since then, more research has been published, now quite deliberately, not accidentally, on ADHD and its treatment than any other childhood disorder, period. There have been multiple, and to give you a sense, over 350 scientific studies, gold standard research in the field, which is typically considered to be double-blind, placebo-controlled studies, and over 6,000 patients over the course of 50 years have participated. So there's a lot of data and research to support the use of the medications that we do today. Medications have been found to be immensely effective. They reduce impulsivity, hyperactivity, and inattention. They improve academic performance and peer interactions, social interactions, clearly having a huge positive impact on the lives of children and families who are suffering from ADHD. We know the side effects well because there's been over 50 years of experience with these medications, not only in research, but also since they've been on the market, since the 1960s. So we know the medications well. Medications consist of both stimulant and non-stimulant treatments. I'll talk to you about both. The stimulants are the most effective treatment, and we think they're effective for about 75 to 80% of those with ADHD. That's a very high rate of effectiveness, higher than any other category of medication available to the pediatric population, period, beyond mental health diagnoses. The name stimulant now actually comes from studies that were performed many years ago in which high doses, much higher than any therapeutic dose that we would use in a child, much higher doses of medication were given to rodents in laboratory tests, and these doses actually stimulated their physical activity, and that's where the name stimulants comes from. In reality, the way the stimulants actually work today is they actually allow for increased levels of the neurochemicals that I mentioned earlier, the ones where we think there's a deficit in certain key parts of the brain, dopamine, norepinephrine. What these medications do is they allow those levels to be increased to provide their therapeutic benefit. The stimulants actually occur in two families, the methylphenidate family and the amphetamine family. The active ingredient in each family, each medication in that family is the same. The individual differences occur in how the medications are each manufactured to reduce symptoms for a specific time, specific range of time during the course of a day. Medications you may have heard of in the methylphenidate family include Ritalin, Focalin, Methylin, Ritalin LA, Focalin XR, Metadate CD, Concerta, Daytrana, Quilivin XR and Quilichu ER, and Eptensio XR. The other family, the amphetamine family, again, agents that I'm sure you've heard of include Adderall, Adderall XR, Dexedrine, Dexedrine Spantial, Vyvanse, Avecchio, Zenzetti, Dianaval XR, and Adzonize XR ODT. So stimulant side effects are generally mild and tolerable. Common side effects include decreased appetite, insomnia, headache, stomach upset, nausea, and mild increases in heart rate and blood pressure. And it's important for me to say now that when the comprehensive evaluation for ADHD is being done, and a clinician believes that a child or an adult has ADHD that warrants treatment, that has significant impact on their functioning and is causing distress, it is critically important to gather a comprehensive history, including a medical history, and especially a neurological history and a cardiac history. And to make sure that that child has no cardiac symptoms, such as passing out or nearly passing out, either in the context of activity or even without being active, and no history of palpitations, chest pain, doctors saying they have a murmur, or a family history of individuals in their family, parents, aunts, uncles, relatives, grandparents, who have a known cardiac condition, especially a electrical heart defect or an anatomical or structural heart defect. Those children require an evaluation by a pediatric cardiologist before any ADHD medication can be considered. When that is not the case and there's no personal or family history, or you've done the evaluation and the cardiologist has done all the tests, which should include an echocardiogram and an electrocardiogram, and of course a history and physical exam. And if all of that, the child has a clean bill of health, then prescription can proceed. If there's no need for that type of testing and evaluation because the child and the family don't have a cardiac history, medication can also be safely prescribed. And again, mild increases in heart rate and blood pressure are found. There may be behavioral rebound, so when the stimulant wears off later in the day, sometimes we'll see sort of an accentuation of ADHD symptoms. It's something to be very clear about with families. We used to believe that tics were a manifestation of stimulant treatment. We now know better. We know that tics, and for that matter, anxiety disorders, are highly correlated with ADHD. And for some individuals, stimulants actually reduce tics. But there may be a few where there's an exacerbation of tics and anxiety with medication, and we want to be mindful of that and address it as needed. Long-term effects on growth are, to be honest, not clear-cut. There have been lots of studies. Some studies seem to indicate that ultimately individuals are the age they would have been regardless of treatment intervention, are the height they would have been regardless of treatment intervention. Other studies seem to indicate that individuals may ultimately be 1 or 2 centimeters shorter than those who did not receive stimulant medications. Other studies seem to indicate that that's not the case when individuals receive drug holidays and are not consistently on medication for years and years every single day. So studies seem to show different things. The bottom line is to weigh the risks and benefits and make the decision that's in the child's best interest, and then to medicate conservatively, thoughtfully, carefully, and to make sure that height, weight, heart rate, blood pressure are being monitored as the child is treated. Some children are not able to be administered stimulants for medical reasons. Again, the children with cardiac histories or cardiac exam that shows findings that are concerning. And so non-stimulants are a safe option. For other children, the side effects of non-stimulants may be better tolerated than those of stimulants. So the choice may be to go with a non-stimulant, even if they may be safely prescribed a stimulant. Non-stimulants are not as effective for ADHD symptoms, especially for the inattentive part of ADHD. So that is a caveat to be aware of. For those who don't have a medical contraindication, however, we can pair stimulants and non-stimulants together. So in fact, the sum is greater, together they work better than either individually. So we can actually get good benefit and mitigate side effects in the process by combining a stimulant with a non-stimulant. So non-stimulants are less potent, but may be a good choice independently or together with a stimulant. Some non-stimulants include the alpha agonists, guanfacine, brand names are Tenex and Intuitive, clonidine, the brand names are Catapress and Capve, atomoxetine, also known by the brand Strattera, bupropion, known by the brand Wellbutrin, modafinil, which is prescribed for narcolepsy, also known as the brand Provigil, and also omega-3 fatty acids. There is an indication that omega-3 fatty acids may have mild benefits. They are nowhere near as potent as some of the other non-stimulants or clearly the stimulants, but they can be an initial intervention. So why treat ADHD with stimulants? Medication treatment for ADHD clearly reduces symptoms of the disorder and is necessary when a child has dysfunctional symptoms and an impact on their life. There's notable reduction in impairment and improvement in health-related quality of life. Best long-term results are achieved by combining medication management with other treatment interventions. Non-pharmacologic interventions for ADHD are critical and include support groups, social skills groups, behavior modification strategies at home and in school, organizational skills training, school-focused interventions, and it is critical that evaluation and treatment of coexisting learning disorders or additional psychiatric conditions also be pursued. Resources in the community include Children and Adults with ADHD, CHADD, chad.org, the American Academy of Child and Adolescent Psychiatry, ACAP, has an ADHD resource center, acap.org is their website, and Attitude Magazine, attitudemag.com. Now I'll turn to you for your questions. So question 1, my child has ADHD, is on the spectrum, and also suffers from an anxiety disorder. Don't stimulants contribute to the latter? So again, we now know that anxiety disorders and ADHD often co-occur. So it may not be the treatment itself That being said, there are some individuals that do, in fact, have a exacerbation of anxiety from certain types of medications, possibly stimulant medications. So we do have to have a very thoughtful approach. Typically, if a child warrants treatment for ADHD, a good rule of thumb is to start with a low dose of a psychostimulant because it will likely be the most impactful treatment, and to see how well the medication is tolerated. There is some level of trial and error involved. If there's no contraindication, no cardiac contraindication, this would be generally a very conservative and appropriate strategy. If the child can tolerate it and has, unfortunately, an elevation in anxiety, then one may want to think about, do we try a non-stimulant such as atomoxetine or an alpha agonist, or combine a lower dose of the stimulant with a non-stimulant. Next question. If medication is necessary, when is the right time to start? Is age 4 too young? So it really is a matter of the impact of ADHD. The right time to start is when there are significant symptoms that are impacting on a child's functioning, their self-esteem, their ability to be social, their ability to be a student. That's when intervention is needed. The first interventions can be non-medication. They can be interventions at school, at home, the kinds of things that I briefly went over towards the end of my talk. We do have the preschool attention deficit hyperactivity disorder treatment study, PATS, which did seem to indicate that young children, the preschool age children, are less responsive to the treatments than their cohorts that are 5 and older, so school-aged older kids. So you want to be very thoughtful and try other interventions first because they may be less responsive at that young age. But if a child has severe symptoms that are impactful, some of these medications are FDA approved as early as age 3 years. Our third question, will drug-seeking behavior start at an older age if a child age 6 to 7 remembers the experience of taking Adderall? Lots of studies have been done on individuals with ADHD, untreated, and individuals with ADHD that's been treated, looking at this question of substance use. We do know that adolescents and adults with ADHD are at much higher risk than the general population for substance use. We believe from the studies that have been done that early treatment, not just medication, but wraparound care, interventions at school, interventions at home, social interventions, medication, all of these will address ADHD and its impact and reduce long-term consequences, including substance use. What you should know is studies have been across the map. Some studies have shown exactly that. Others have failed to show that impact on reducing substance use. So there's more for us to study and more to determine about how these treatments can impact long-term functioning and reduce risks of things such as substance use. Question 4. Due to gene deficiencies, my son doesn't respond to any ADHD drugs. What other category of drugs can help him to improve focus? That is a complex question. And without knowing details, it would be important to know what has been tried, how clear it is from the testing that's been done that these medications absolutely cannot be pursued. There are, in fact, genetic tests now that will actually give you a sense of what medications may be effective. Typically not the first thing that we do, but certainly something in a case like this that might be a helpful tool. But as I said in my talk, there are stimulants and also non-stimulants, so there are a lot of options. So if a stimulant can't be used, then there are a wealth of non-stimulants that can. Strattera or atomoxetine, the alpha agonists, bupropion, Wellbutrin, and other agents that I didn't even list in my talk. So there are quite a few options. This is our 5th and final or last question. What is the usual length of time that a child is on medication? Is there an average age when they outgrow it? So that's a great question, and it has to do with also the epidemiology of ADHD. As I mentioned, it looks like about 50% of children with ADHD grow up to be adults with significant ADHD symptoms. So development plays a role, and some individuals do, again, for lack of better words, outgrow their ADHD symptoms. It really is a case by case, and so as a clinician, and many other clinicians I think do similar things, is from time to time we will take a drug holiday, a break. Sometimes that happens during the summer where we give a child a break from medication to see if they are ready for a lower dose or to be tapered off their medication. I have clients who are highly functioning professionals at this point who've stayed on medication because they continue to feel that they need it and that it has a tremendous positive impact on their well-being and their functioning. And then I've had some individuals who, by the time they were in high school or college or soon thereafter, were able to be taken off their medication. So thank you for your questions and for your time. On behalf of the Child Study Center, thank you for joining me today. Once you leave the webinar, you will receive a survey, and we would we would appreciate if you would complete it. You will also receive a follow-up email within a day or two with a link to a recording of today's presentation. We hope you can join us for our next webinar, 13 Ways to Talk to Your Children and Teens About the Media, with Drs. Randy Pachter and Samantha Busa. That's on Tuesday, March 13th at 1 p.m. Thank you again. Goodbye.